Labor analgesia is like Mahabharata's Padmamyuham, where Abhimanyu knows to enter it. Labor analgesia is very easy. Put an epidural, put the catheter, give the medications. But if a complication comes, you have to find a solution, and you have to bring yourself and the patient out of that complications. And that is the key. There are 4 important caveats for obstetric anesthesia practice. You should know what to give, and how does it affect labor and delivery of the baby, and neurological complications of labor, epidural, and diagnosis and management of post-dural puncture headache. I will just give you a little bit of overview. Dr. Vijayashree has mostly touched upon most important aspects of post-dural puncture headache. I'll tell you if there are anything we can do to prevent the post-dural puncture headache from spinal, from epidural, and if there is a wet tap, how to prevent the post-dural puncture headache, and of course, finally, how to treat. Augustine Bayer himself tried spinal on him, and he got actually post-dural puncture headache. And he said, most likely, this is due to, I just want to show a small video here. You can just try that. Of course, you don't do this, but I just want to make one point here. There goes the epidural needle, and once the epidural needle goes, when she takes this stylet off, which is a bad technique, that's why I wanted to show. And this is how you get a dural tap. So basically the point you're trying to make here is, when there is a hole, it's a small or a big hole, the fluid is coming out. So when the fluid comes out, what happens is it actually pulls the brain and its structures down off the cranium. And what it does, it actually puts traction on the vessels, and it actually puts traction on the nerves that are coming from the base of the brain and exiting to the foramina. This is the basic concept of what happens in a post-dural puncture headache. Now, the size of the needle matters. That's what Dr. Vijayashree said. The smaller the needle, the lesser the incidence. And that's why I showed you the other one. If someone has got an epidural needle, usually the incidence of headache will be about 50% roughly. Another important thing is a needle tip design, particularly for spinals. There are cutting needles and pencil point needles. What happens in the pencil point needles is they create a ragged edges. So there is some sort of an inflammatory response, so therefore they heal much better in pencil point. Whereas in a cutting needle, they're very sharp, and therefore they do not heal very well. It is like a knife incision, and therefore the leak is likely to occur more. That is why pencil point needles are more preferable. These are various types of the needles. We generally use pencil point Whitaker needles, but it all depends upon, as long as you use pencil point needles for spinals, you're fine. Now, can we prevent headache after spinal? If you can use smaller needles, yes, the incidence is less. If you use intrathecal fentanyl, most of the institutions actually use a little bit of fentanyl for visceral pain for cesarean section. That doesn't reduce the incidence of post-dural puncture headache. Some institutions had morphine, Duramorph, which is preservative-free morphine for the post-operative pain relief. That does not decrease post-dural puncture headache, so it doesn't really matter. There is a little bit of evidence that when you get a spinal, you inject the solution. Before you withdraw the spinal needle, you put back the stylet and take it out. So they say that it is probably associated with less incidence of post-dural puncture headache. Then, how do you prevent for epidural anesthesia? We had a lot of discussion about loss of resistance to air, the loss of resistance to saline. Some people think that if you use saline, the incidence is less. The evidence is controversial. Scott Siegel, one of our colleagues, summarized this. In anesthesia analgesia, it doesn't really matter whether you use air or whether you use saline. Bevel orientation. Yesterday, some of the delegates pointed out that if you put the bevel parallel to the fibers, the incidence is less. But no, the electron microscope studies have shown that the fibers crisscross, it doesn't really matter. So that is also gone. What about if there is a wet tap, and what about prophylactic blood patches? Yes, some institutions do, prophylactic blood patches. They did not find any decrease in the incidence of post-dural puncture headache or the need for therapeutic epidural blood patch. But the severity of the symptoms and the duration of symptoms were less. Epidural morphine is the next alternative that was tried. 3 milligrams of epidural morphine, you give it to the patient, and probably the incidence of post-dural puncture headache is about 12% in the morphine group versus 48% in the placebo group. So basically, you are actually providing the analgesia, hopefully during the time that the dural hole seals and the patient will get better. Epidural and intrathecal saline has been tried, and epidural dextran have been tried, but they're all small studies, and there is no conclusive evidence because they're all non-randomized studies. Leaving intrathecal catheter has got some value. One study showed that yes, it decreases the risk of post-dural puncture headache. Others reported no clear benefit. But one thing is you have to leave the catheter for 24 hours. And International Journal of OB Anesthesia in 2009 summarized all these studies, and they found that yes, it does make a difference. From 66% to 51% is incidence of headache. So it decreases. But remember that you have to leave the catheter for 24 hours. So your setup has to be very good, that no one injects them or no one tampers with those spinal catheters. So that is an important thing you have to keep in mind before you implement this. Because if you leave the catheter, during the labor and delivery, it plugs the hole. So when the CSO pressure goes up, when the mother is pushing, probably the leak is decreased there. And it also sets up an inflammatory response. Diagnosis, Dr. Vijayasri has done an excellent job in telling you what exactly is the incidences. Overall incidence of post-dural puncture headache, which we quote our patients, is roughly 1.5%. One interesting thing, when Dr. Vijayasri said, in our institution, as soon as the patient complains of headache, they call anesthesiology. So we go there, look into the chart, the patient never had a epidural at all. So this is how everything is done. One thinks headache after epidural is a post-dural puncture headache. It is not so. So, we all laugh about it. But that is the key you have to remember. So you have to educate your staff wherever you are performing these procedures. They usually occur between 48 to 72 hours, but we did have cases where they occurred within 24 hours, very severe because of the leak. Sometimes the needle could go through and through, one hole this side, one hole other side, massive leak, and patient complaints of headache even within 24 hours, and even with some other neurological symptoms, which I'll explain. They have neck pain. The neck pain is, typically the headache starts off frontally and goes to the back. And then they have a neck pain which is responsive to the headache. So there's a spasm of the neck muscles. If you give a little bit of pressure on the abdomen, there is some sort of a relief. So that is one of the diagnostic features. Head down tilt is relief. And sometimes they get tinnitus and diplopia because of the adjacent nerve and also the vestibulo-ocular nerve. They go through the foramina, so they are under traction. So if they develop this within 24 hours, probably it is a severe fluid leak. And if it is postural, we go ahead with the blood patches a little more quicker in those patients. This is just to show you the radiological findings. There is enhancement of the packing meninges because of the low tension in the head. And there is a crowding at the foramen magnum level because the optic chiasma comes down, the cerebellar tonsils could herniate, the pons becomes flatter, and actually it can mimic the Chiari malformation type 1, because the whole brain, as I said, is sinking down. This is the complication of subdural hematoma. I showed you in that picture, there is a traction on the dural sinuses because the brain is sagging down, and if you don't push up, sometimes it could rupture and patient can develop subdural hematomas, which we need to manage. We had a couple of cases, and finally, after the neurologist saw, after CT scan, we did give blood patches to them in order to push it back. Has been just done. This is the press, which has become a recent publicity. If you sit in any of the conferences, now everyone is showing this because it's a recent addition to our literature. Particularly occurs in preeclampsia hypertension, where the occipital areas are a little dense here, and that is because of edema. And as she pointed out, and it is usually associated with visual symptoms, they're self-limiting. They go away within 48, about 3-4 days. But this is something which we have to keep in our mind. Now, what is the treatment? The treatment is push it up. How will you push this? Now, we'll come to that. Treatment is conservative. Initially, you can try conservative measures like bed rest, supine position is of no benefit. And rehydration, NSAIDs, anti-inflammatory drugs, opioids, antiemetics have been tried. With some sort of a limited success. And we use a combination of actually acetaminophen, caffeine, and butal-butal. That is our combination, and which you can translate into the drugs that are locally available. Abdominal binder sometimes relieves because it actually puts the pressure, but it is uncomfortable for the patient. Pharmacological treatment, caffeine sodium benzoate, 300 to 500 milligrams intravenously, now at best had some transient effect. So sumatriptan has been used, ACTH, and yesterday actually someone asked in one of the things, how much of ACTH? ACTH, roughly about 80 international units, IM, or 1.5 units per kilo, in about 1 to 2 liters of Ringer's lactate given intravenously. Is supposed to produce pain relief. But again, there are no large studies on this. And we have used it in those cases where epidural blood patch was contraindicated because of coagulation issues like von Willebrand's. Gabapentin 900 milligrams 3 times a day for 4 days has been found in some studies with some limited success. So we attempt this conservative management for about 24 to 48 hours. And if there is no relief, we actually put a blood patch on the second day. If the headache is increasing or the patient is distressed, because we do explain the process of blood patch, if the patient still understands that, says, I want a relief here, and I can't even hold the baby, then we go for the blood patch. But if the headache is coming down, at that time, we probably wait and watch, and it could be self-limiting. In about 5-6 days or even a week, the headache will disappear. Or at least it is tolerable for the patient. The longest, my mentor, Sanjay Datta, told me that one day, the longest headache he saw was 1 year. And the patient was almost at the point of committing suicide. When a prudent anesthesiologist diagnosed this as a post-dural puncture headache and gave a blood patch, and she became fine. So you have to follow up these patients if they do get post-dural puncture headache. Treatment, the blood patches have been done since 1960 because one of the observations was if there was bloody wet tap, when you put an epidural needle, you got little blood, the incidence of headache in those patients were actually less. So blood really works in those areas. So although normally the earlier studies said that the blood patch success rate is about 90%, we generally say it's 70% because the recent studies probably the first blood patch is 70% and the second blood patch is about 90-95%. These are rough figures which you can give it to the patient. These are the other alternatives like epidural saline has been tried either by infusion or bolus. Dextran gelatin patches have been tried. Fibrin sealant patch is under investigation, but the definitive treatment today, if someone has a post-dural puncture headache, where the conservative management is not effective, is actually epidural blood patch. So that's what I was telling you. If you are continuing to practice labor analgesia, you should also know how to manage the complications, how to educate the neurologists about these complications, because not all complications not all headaches are post-dural puncture headaches. You have to exercise the differential diagnosis. We had patients with cortical vein thrombosis. We had patients with subdural hematomas unrelated to, post-dural puncture headache. And so you have to actually, or cavernous sinus thrombosis. So you have to keep all these differential diagnoses in mind. Diagnosis of the tumor for the first time, preeclampsia. You have to rule that out, because if you do a blood patch in a preeclamptic patient, there is already cerebral edema, patient will seize. We had a patient who seized after giving blood patch because the patient actually had preeclampsia. In summary, small pencil point needles are probably the best. Epidural, there are several proposed methods to reduce risk of post-dural puncture headache after wet tap, but none are really magic. Treatment is the epidural blood patch that remains the gold standard as of today. If you are planning to do a blood patch, you have to have a good IV. Hemodynamics, I said, rule out preeclampsia. If you have any doubt, consult the obstetrician. Let them do urine exam, whatever they want. Make sure that they are involved in the process and rule out preeclampsia. Now, what happens when the brain sags down? There is a pressure on the brain stem. So how does it manifest? Hypertension and bradycardia. We had a patient whose heart rate was in 30s and 40s with high blood pressure. That is an alarming sign after post-dural puncture headache, if you think it's a diagnosis. We did all the studies, we consulted neurologists, and we actually did the blood patch and observed the patient for 24 hours because we were worried about low heart rate in that patient, and she became fine after that. So that is the extreme case of post-dural puncture headache. Then you give the blood at the lowest possible place so that the blood usually tends to go up. And then I tend to give until the patient feels pressure at the back. There is a recent study where they tried with 10, 20, 30 ml. They found the best results with 20 ml of blood given. So the choice is yours. You can use either way, it's fine. 2 hours, we usually leave the patients 2 hours supine after the blood patch, and immediate relief and sealing of the hole. So what happens is this. As soon as you give the blood patch, the patient feels very good. Why is it just happening? That is because you are pushing the pressure on the dura. It pushes the CSF, increases the CSF pressure, pushes the brain stem, and produces immediate relief. And then the blood which you have injected will try to seal the hole, and hopefully the patient will get better. But sometimes the hole may not be a proper seal, or suppose we made a through and through hole, this side one hole, that side other hole, then probably it will take a little while, or you may have to do second patch. And usually, when you give blood, what happens to it? It usually starts disintegration from 3 to 6 hours actually, as soon as, and they usually disappear within 24 hours. By the time it sets off that inflammatory response, and then you can get the sealing there. This is what I always tell the patients. You will get back pain because the blood could enter the small hole or the big hole, whatever it is, and into the CSF put chemical meningitis. And so you have to explain to them so that they understand, so that they don't get too nervous about it. Actually, this is a video which this is a video. I don't know if you can listen to the sound. This is actually from India. I was actually doing a search in YouTube. And anyway, there's no sound. It is actually, they explain this in Hindi to the patient. And so he's got the epidural located, he's injecting the blood. The patient is monitored, actually could hear the pulse ox sound, and they keep asking the patient how she feels. And one thing you have to be careful is absolutely aseptic. Epidural technique, wherever you're drawing the blood, tunicate everything in place.
पीठ में थोड़ा सा दर्द हो रहा है ना, वो अभी ठीक हो जाएगा. अभी वहाँ सुई लगी हुई है ना, अभी कम हो रहा है सिर दर्द, वो अभी ठीक हो जाएगा. अभी वहाँ सुई लगी हुई है ना, अभी ठीक हो जाएगा. ठीक है. अभी कम हो रहा है सिर दर्द, क्या? अभी ठीक हो जाएगा. ठीक है.
So the technique is very simple, but it is very effective for the post-dural puncture headache treatment.